Good evening, everyone. Today, we are going to have yet another session of case-based discussion of psychoureteral reflux. You all know this is a very important pediatric urology topic, and with lot of confusion about the management. Today, we have got Dr. Ramesh Babu, who is a senior consultant and head of the Department of Pediatric Urology in Ramchandra Medical College, Chennai. And with us, the student is Dr. Harish Chala, who is a final year MCH student in Ramchandra Medical College, Urology. Over to you, sir.
Thank you, Dr. Nitish. So generally in the examination, VUR is kept as a short case or in the form of a case discussion during a ward rounds. And most of the time, these patients not have much symptoms, signs to elicit. So these are often discussed in Viva or ward rounds, where the patient is kept, the images are shown, and then we start a discussion. Basically, the X-rays or the symptoms start as a point of discussion. And then the questions basically are a point related to the evaluation and management of VUR. So what we thought is, again, we will have similar kind of ward round or a Viva kind of discussions where I'll give case scenarios and then we will ask Dr. Harish the questions, right? So we'll go ahead to the first case. This is a 3-day-old female neonate. Antenatal scans showed bilateral mild hydronephrosis. The anteroposterior diameter were 8 and 9 millimeter on the right and left side. The bladder is normal, the liquor is normal. And that is the image you see on the antenatal scans. Now, Harish, do you want to tell what would you be the thinking and what would you do further for this patient?
Sir, 3 days female neonate with antenatal hydronephrosis, that too mild. It is very mild, 8 to 9 mm APD diameters, and there is no hydroureter, sir, in this patient. Okay. And till now, the patient has 3 days only. There is no history of any UTIs, and bladder is normal, liquor is normal in antenatal scans. That means this patient can be managed conservatively, sir. I mean, you can just follow, do your ultrasound first initially after 72 hours. I mean, now today it is 3 days. Now can proceed with ultrasound scan, initial ultrasound scan, postnatal.
So this is an ultrasound which you can see, which shows that for the 72-hour ultrasound. Can you tell me what you can see on the right side and left side?
Sir, as compared to right, left side has mild HUN. Right side, it's SFU grade 1 or grade 0. It's left side is grade 1 or grade 2.
Okay, I will not go into the discussion about the SFU grade now because we've already discussed it in the previous class. Now, with this ultrasound picture, what is in your mind? Again, is it the same thing you are thinking in the form of a transient hydronephrosis?
Yes, sir. I am thinking it's of a transient hydronephrosis which can be managed by follow-up. And maybe the patient, we can do another repeat ultrasound scan at 3 or 6 months. If there is still persistent hydronephrosis, patient can be managed on follow-up only, sir. MCU, there is no need, but for baseline investigation, we can do MCU at a single
What are the typical indications for an MCU in a case of an antenatal hydronephrosis?
Sir, MCU indication in antenatal hydronephrosis is along with hydronephrosis, if there is a presence of hydroureter, or antenatally there is a decreased liquor or any bladder changes that suggestive of any obstructive pattern with hydroureter, then we can plan for MCU post-op as a early MCU, sir, maybe at 1 month period.
Okay. So this patient, let us say that you are following up. When will you be your first ultrasound?
Sir, first ultrasound is at 72 hours, sir.
No, after that is done.
1 month, sir.
1 month.
Actually, this patient is a low risk patient. We can even delay the next ultrasound up to 3 to 6 months, sir. Next ultrasound at 3 to 6 months.
I would stick to the 1 month because again, still the first week ultrasound is relatively underreporting whatever.
Underreporting.
So I would still do the ultrasound at 1 month. Now
Yes, sir.
this patient probably had some suspicion of query infection at around 3 months of time, and
Okay,
now
sir.
they have done this.
MC.
Okay, so in a patient with antenatal hydronephrosis, if there is any suspicion of UTI, then you
Yes, sir.
go for an MCU,
Yes.
or there is any doubt that the hydronephrosis is not resolving or it is increasing in size, but it is more midst of mild hydroureteronephrosis, then you can do an MCU. Now, can you tell me what do you see on the MCU film?
Sir, MCU and left side, it is a grade 2, that means non-dilated ureter, reflex up to the pelvis, and on right side, it's like a grade 3 with mild dilated ureter, and grade 3 VUR, sir.
So
And
how do
right,
you grade vesicouretic reflux, and who described this grading?
sir, International
Reflux Society.
Reflex Society, yes, sir.
Okay.
And
how do you
it was
grade?
divided into 5 grades based on MCU. It is grade 1, it is a non-dilated ureter and reflex up to the ureter only. And grade 2 also non-dilated system with reflex up to the pelvis. And grade 3, there is a mild dilatation of the ureter, but no loss of papillary impressions with no tortuosity. In grade 4, there will be a mild tortuosity with moderate dilatation of the pelvic calcium system and also the ureter, with flattening of papillary impressions, whereas in grade 5, there is a loss of papillary impressions. Then clubbing of calyces will be there, along with more tortuosity and severe dilatation of the ureter and pelvis. Pelvic calcium system.
Why is it important to grade like this? How does it help?
Sir, grading helps in follow-up of the patients, and whether the patient needs antibiotic prophylaxis or patient needs intervention in case of a grade 5 reflex in females. Mainly in follow-up.
Apart from that, there is one particular thing the grade will help in vesicouretic reflux. What does it determine? What is the natural history of vesicouretic reflux?
Primary or secondary, sir?
Now, I'll come to that. What is the natural history of vesicouretic reflux? The usual natural history of vesicouretic reflux is what?
Defective VUJ, sir.
No, that is the etiology or whatever. Natural history means what happens when you follow them up normally.
Sir, it will resolve, sir. That means follow-up resolution will be, you can.
So does your grading help in predicting the resolution?
Resolution.
Does it help?
Yes, sir.
So you tell me what is the resolution rate for each grade of reflux?
In non-dilated VURs like grade 1 and grade 2, it's around 90%, sir. And if it goes to grade 3, it is around 50 to 70%. If it is a bilateral grade 3, it will be around 20 to 30%. Only unilateral grade 4, it is around 30 to 40%. And if it is a grade 5, it is less than 10%, sir.
So it helps a lot in telling the family and counseling them what is going to happen. So that is one of the main advantages of this kind of grading. It helps in predicting your natural
resolution.
Right. Now you told about this primary and secondary. So what do you mean by primary and what do you mean by secondary reflux?
So primary means the defect is within the VUJ junction. Intravesical ureteric junction and trigone dynamics. And the association between ureter and trigone alteration any leads to reflex, then it is called primary VUR with no secondary causes. Whereas secondary VUR, it may be due to bladder pathology. That may be neurogenic or non-neurogenic component. Neurogenic, it may be due to spinal diaphysems or myelomeningocele. Non-neurogenic, it may be due to Hinman syndrome or dysfunctional elimination syndromes, or it may be due to posterior urethral valves or ureteroceles, which may be prolapsing in females, normally causing obstruction.
So when you read a MCU report,
yes, sir.
Do you straight away go and then start reporting on that reflux, or will you look?
No, sir. First, you have to start on the bladder. How is the bladder? Whether its shape is normal.
You didn't tell. That is why it all came. So you tell me, like, what is the bladder appearance in this case?
Sir, bladder appears to be mildly irregular, sir. But whatever appearing portion of urethra, it is not dilated because it's female. There is no chance of other causes of obstruction. Bladder neck is normal. and right side there is a grade 3 reflex, and left side there is grade 2
So
reflex.
whenever you report an MCU, you start like in a scout film, no bony abnormalities, spine
Yes,
is normal, sacrum is intact. Then you go to the distal urethra, how does it look? Then how is the filling
bladder
phase,
neck.
the voiding phase? Obviously, I didn't give you a lot of images. So you should
Yes,
have told me, you have given only the filled phase or you have given only the voiding phase. You have not given
yes,
me all phases. Okay.
yes.
How is an MCU performed?
Sir, MCU can be performed through periurethral catheterization and filling the bladder, sir.
Okay. What do you fill? So contrast agent, right? What contrast agent normally we use?
Iodinated contrast
Yeah,
agents, sir.
iodine-based contrast agent.
Iodine-based contrast agents. It
Yeah,
may be normally we use ionic, sir, because it is cheap and it is
can be
not injecting
ionic,
into IV. We
non-ionic.
use non-ionic.
And then do you dilute it?
Yes, sir. Dilute in 1:1 proportion, sir.
Okay. And then what are the precautions you need to take before an MCU?
Sir, patient should be well hydrated.
No. That is different. You're getting about an
Yes,
MCU
sir.
I'm talking about.
Sir, bowel preparation, sir, day before.
Generally, it's very difficult in children to do a bowel preparation and all. What else?
Normally, you use feeding tube instead of any Foley's catheter.
That's okay. That's okay. But in preparation of an MCU,
Yes,
I mean, there are a couple of things where you make sure that is not there or there. Like what?
don't know,
So
sir.
before doing an MCU, I mean, what are the risks of an MCU?
Sir, radiation, sir, very high radiation.
That is okay. Then what else?
Mm,
When you do an MCU, what can the child develop?
allergic reactions, sir. Very rare.
Be more clear. Like when we do an MCU, particularly in a little baby like this,
Yes,
what
sir.
are we worried about? What can that baby can develop something and then even end up in the hospital getting admitted.
Anaphylactic.
No. So what is it an invasive procedure or non-invasive procedure?
It is an invasive procedure, sir. We have to
So-
catheterize the patient and then you have to fill the
what is
bladder
the
with contrast.
problem? What is the problem? When you put something inside a cavity, like
Yes,
bladder
sir.
particularly, or urinary tract, what is the risk you're worried about?
Rupture.
Let us say that the child develops fever and gets admitted later.
Yes, sir.
What is that due to usually? After your
Infection.
MCU, the child develops fever and then gets admitted. What did you say?
Infection, sir.
Yeah,
We are introducing the infection.
absolutely. Infection is one of the important risks in children. They can develop a severe sepsis and then they can get admitted also. That is one of the major risks, particularly in neonates.
Okay,
So
sir.
before you do an MCU, you have to make sure that
Start an antibiotics, prophylactic antibiotics. One day before.
what do you do? I mean, do you do any urine test?
Yes, sir. Urine routine, urine culture we have to do to rule out.
So you have to
Actually,
make sure
before doing
that
MCU, patient should be
the
sterile, sir.
urine
I
is
mean,
clear. Number one, that
Yes,
is an
sir.
important thing before an MCU. And then
Okay,
when
sir.
you do the MCU, you have to make sure that you take all the aseptic precautions.
Yes, sir.
Okay. I mean, these are all basic things you have to tell when you are asked, I will
Yes,
make sure that the urine is clear, the urine is not infected. I'll take all aseptic precautions. Then I will use quite a good amount of lubrication
Feeding
and then
tube.
try to catheterize using a feeding tube. I will take a contrast at a dilution of whatever,
1:1.
ionic or non-ionic, 1:4, and then I will fill up slowly depending upon the bladder capacity of the
Capacity.
child. So how do you assess the bladder capacity of the child? What is the formula?
Sir, above 1 year of age, it is age into 2 plus 30, sir. Below
Age
1
into-
year of age, it is
so
weight plus.
wait. Age into 2, is it?
Yes. Age. Yes, sir. Age into 2 plus 30, sir.
No. It's not times. Times 30 is fine. Times 30 is like an ounce. So how many ounces are there? It's age plus 1 or age plus 2. Some people say it's age plus 1 or age plus 2. So
Age plus 2, sir.
in a 3-year-old, what is the bladder capacity?
Sir, 3 plus 2, 3 into 2 plus 30, sir.
No, that you work it out.
36.
That's wrong. That is wrong. So it is not 3 into 2.
3 into 30.
So in a, let us say you have an 8-year-old. What is the
Yes,
bladder
sir.
capacity?
Oh, it comes less, sir. 8 to the 16 plus 30, it will come around
No,
46.
it is not multiplication. So it is just age plus 2. Some people
Yes,
say
sir.
age plus 1. Okay.
Yes,
So in an 8-year-old, it is like, 300 ml capacity. In
okay,
a
sir.
2-year-old, it is probably 100 ml or 120 ml capacity.
Okay, sir.
Okay, so you need to know the formula and then fill it accordingly. Anyway, I
Yes,
mean,
sir.
these are all some questions that can be asked. Basically, it doesn't have to go, the important thing which you need to know is in any exam, the question does not have to go straight into BUR and then its management and then whatever you have prepared, because most of the examiners know that you have prepared for this particular condition, this particular case, and it is not a secret that you are getting this case. So you will know what case you are dealing with. The examiner will know what case you are dealing with, but only the line of questioning is to just bring out whatever the overall knowledge you have. So it can go in multiple directions that you have to be aware of. All
Okay.
right. Okay. Now you've told about the grading of VUR. So in this patient, you think it's a primary VUR or a secondary VUR?
It looks like a primary VUR, sir.
So what
There
are the
is no
chances of
outlet abnormality is not there,
what
and
are
bladder
the
appears to be
chances of
smooth.
resolution in this patient?
Sir, this patient has it's grade 3, grade 1. Patient can be maintained around 70% of resolution, sir, by 5 years of age.
Okay, so will you put them on antibiotic prophylaxis?
Sir, as a rule by Indian Academy of Pediatrics, all grades of reflex below 1 year of age will start an antibiotic prophylaxis, sir.
Okay. So, but in general, nowadays the role of antibiotic prophylaxis is
Yes, sir. They
confined
are.
to dilating VUR.
Yes, sir.
So, which is 3, 4, and 5.
5.
Obviously, this child has got a grade 3 on one side, so definitely you will start them on antibiotic prophylaxis.
Yes,
what
sir.
antibiotic prophylaxis you will start?
Sir, baby is less than 2 months, so better we cannot start nitrofurantoin or trimethoprim sulfa group. So we have to start in cephalexin or ampicillin in half of the normal dose, only night time, bedtime.
Okay. Okay. Right. So that is fine. And what about now? We will go to the next case. I don't know whether Dr. Nitish is still there or is gone. Okay, now let us go to the second case. Is a 7-day-old male neonate, antenatally diagnosed bilateral mild hydroureteronephrosis. So the baby is now 7 days old. So what do you want to do?
Sir, I want to. This is a hydroureteronephrosis.
Okay.
So on 7 years, bilateral is
7
there.
days, 7 days old.
7 days. I have to get first ultrasound followed by MCU, early MCU.
Okay. So reason being?
Sir, reason being because male, the two bilateral HUN, we have to think of PUV as one of the differential diagnosis, but it is given as mild, not greater than 20
ml. In such a patient, would you have waited till 7 days?
No, sir.
So
normally shouldn't wait.
You would have done a much earlier MCU, right?
Yes, sir.
At 24-48 hours.
24 hours, 24-48 hours.
Was delivered elsewhere and then brought it 7 days, and then an MCU was done, as you mentioned rightly. And
yes,
then now you read the MCU.
Sir, it looks like a bilateral grade 5 reflex.
No,
sir.
I said that don't go directly.
I mean, sir. Okay, sir. Bladder appears to be smooth walled and a good bladder capacity. There is no trabeculations. And there is no difference in caliber between the anterior and posterior urethra. Bladder like appears to be normal. And this looks like bilateral grade 5 reflex.
What about the bladder and contour? You see, you tell
yes, sir. It's normal, sir. Regular. There is no trabeculations.
No
contour
trabeculations.
is normal.
Okay.
Yes.
Then what does the reflex look like?
Reflex is to look like grade 5 reflex, sir. Bilateral. Grass dilated tortuous ureters with clubbing of the calyces. Here, clubbing of calyces is there. Bilateral.
Now on the right side, there is something else also. What is that called?
So the right side, there may be associated secondary PUJO, sir. It's look like.
No. That is not what I'm talking about. I mean, in the image, you are seeing something else apart.
Yes, sir. That is contrast within the renal parenchyma. That is due to intrarenal reflex, sir.
So there is an intrarenal reflex. So sometimes
yes,
you see that, and then that is something which is seen here. Okay.
Yes,
now
sir.
in this patient, what is your management going to be?
So this patient, 7 years male patient,
7
even
days
grade
old,
5,
7 days.
sorry, 7 days old male neonat. Normally, male neonats have a high grade reflexes, but chance of scarring is very less. These patients, even grade 5 reflex also will resolute be on follow up. So better start patient on antibiotic prophylaxis and follow up the patients after.
So I would agree with that. I mean, if there is particularly in a neonate, you just have to put them on antibiotic prophylaxis and follow them up. And what
Yes,
will
sir.
be your follow-up protocol be like?
Yes, sir. At 1 month, after 1 month, I will get one DMSS scan as a baseline investigation to know the status of the kidneys. And along with that, I will get 3 months ultrasound follow-ups.
Okay, so you'll do a baseline DMSA and then follow up with ultrasounds.
Yes,
and
sir.
then keep the child on antibiotic
Antibiotic
prophylaxis.
prophylaxis.
And
Yes.
how long you are proposing to continue antibiotic prophylaxis?
Sir, this is a grade 5. So as per IAP, you can have to continue the antibiotic prophylaxis up to 5 years, or baby becomes toilet trained.
Okay, so until the baby is toilet trained, which is usually 3 to 4 year age,
Yes,
you
sir.
put them on antibiotic prophylaxis. But
Yes.
will you be doing MCU in between, or it depends on the condition?
Sir, actually, this patient no needs again repeat MCU. We can do radionuclide cystogram as a follow-up procedure, sir, in this patient.
Right. So now that you have mentioned about this radionuclide cystogram, we'll come to that in a minute. Now, is there a role for circumcision in this patient?
Yes, sir. Below 6 months of age, chance of UTI between circumcised and non-circumcised neonates is very high, sir. So is it a 7 days neonat? Better we proceed with circumcision to decrease the chance of UTI.
So that is one thing which you can do in this patient if there
Yes,
is
sir.
if there is a this thing. Now let me say that this patient develops a severe UTI at around 2 months of age or 3 months of age. Okay,
Yes, sir.
gets admitted, treated, and then that is the condition. So at that time, like you've got the patient with one episode of UTI also. So is there management going to be different? Will you still do continuous antibiotic prophylaxis, or will you think of?
Sir, if there is a severe UTI, we have to differentiate it into upper tract or lower tract UTI, sir.
We'll come to that. This patient with a grade 5 reflux has
Yes,
got
sir.
this. So
Yes, sir.
will your management differ?
Sir, some studies says even after breakthrough UTI also, we can put a patient on double prophylaxis, sir. I mean, if you are giving one antibiotic, you can start on 2 antibiotics. And if on management with 2 antibiotics, if there is no breakthrough, we can maintain the patient up to 1 year. I mean, if the patient has no problem, and we can follow up the patient, sir. But if patient has repeated breakthrough UTIs, even after double prophylaxis also, then we can do diversion procedures, sir, in this patient, like viscostomy.
Double prophylaxis and all we don't follow because even a single prophylaxis is being questioned. So
Yes, sir.
double antibiotics and all is not at all practiced. Okay.
Okay,
So you just don't mention all the controversial things which are sometimes mentioned in some rare literatures. So we either when the child gets a breakthrough infection, what are the things you have to look at? When there is a breakthrough infection, what do you have to investigate?
Sir, urine routine, urine culture.
No. When you find out the breakthrough infection, what exactly you are worried about? I mean that you are still giving antibiotics, infection is happening means what do you have to ask?
Scarring, sir, chance of no, not scarring.
You should find out whether they are compliant.
Okay, sir. Okay.
Whether they are actually taking the
antibiotic compliant.
Whether they are actually, the child is swallowing or spitting. And then you may change the antibiotic prophylaxis. Instead of giving cephalaxin, you can give something else.
Ampicillin or nitrofurantoin.
Like triamoxol. So you can change it.
Yes, sir.
So all those things are possible. Now, if this patient, like in a 3-month-old or 6-month-old, keeps on getting urinary tract infection and has grade 5 reflux, what I want to know is what kind of interventions are there any options here?
Yes, sir. We can do vesicostomy, Bloxam vesicostomy, or patient you can keep loop cutaneous ureterostomy, sir. Loop or Y-shaped cutaneous.
That is something which you have to keep in mind.
Yes, sir.
In a little neonate where the
less than 1 year of
high-grade reflux and infections are happening, you may have to think that as a possibility, and then you may have to do that as well. Okay.
Yes, sir.
That is the point I want to make. Now, this patient is a 2-year-old female child. It's the first episode of UTI. And what are the points in the history taking which you have to ask?
2 years old female, first history of first episode of UTA. Sir, the patient previous history of any similar complaints like patient any previous history of UTA or any admissions related to UTA, and patient is on any antibiotics prophylaxis in the past for any previous infections, and regarding the patient bowel and bladder habits, how is the bowel and bladder habits are there, and any related symptoms like bowel dysfunction symptoms like any increased frequency in nocturia, urgency is there or not.
So you want to know the full details of the bladder bowel function. You want
Constipation.
to know how, constipation, urgency, frequency, all that. And
Yes,
you said some time ago that you want to know the details of the UTI. So how do you
Yes.
differentiate the UTI from either a mild one or severe one? What is that? What are the things?
Sir, it is divided into maybe upper tract UTI or lower tract UTI. Lower tract UTI is generally low risk. I mean, it may be associated with lower urinary tract symptoms like urgency, frequency, maladressed urine, something like that, or dysuria. Whereas upper tract UTI, it's normally associated with fever, with constitutional symptoms like vomiting, loss of appetite, malaise, like that. Lower tract UTI we can be managed with oral antibiotics itself, whereas upper tract UTI sometimes it needs IV admission and IV antibiotics.
Okay. Now, how do you confirm? Well, when you see this patient first, how do you apart from history? Is there anything in the examination you may want to look at?
Sir, I want to know the gait of the patient. How is the developmental milestones?
Okay.
How is the back, sacrum, everything? Any spinal abnormalities are there on examination? Right.
In the abdomen, anything in particular you want to see? There are two things you can see in the abdomen. What are they? Or 2 or 3 things?
Palpable bladder, sir.
Clinical examination in the urinary tract, there are a couple of points which you can examine in this patient.
Lower abdominal tenderness.
Okay, so suprapubic tenderness, that's fine. Then
renal angle tenderness.
Renal angle tenderness. Then whether the bladder is palpable.
Palpable or not.
Kidney is palpable.
Palpable, yes, sir.
So all those things you can look at.
Yes, sir.
In the clinical examination. Now, after clinical examination, if there is a fever or if the child is unwell, then what will you do?
Fever and unwell, I will get the urine routine and urine culture, sir.
Okay. How long will urine culture take?
Urine culture normally takes 2 to 3 days. But
so you'll ask them to go and come back, or what will you do?
No, sir. First, I'll get the urine routine. If urine routine showing, I mean, like nitrate test, leukocyte esterase test, and if there is a presence of bacteria, and this is a high sensitivity and specificity of above 90%, if 3 are combined. So if all are this present, then I admit the patient based on the condition because patient is sick. So I admit the patient and start an empirical antibiotics, sir, like third generation cephalosporins.
Good. So you have to go by your urine routine test, and then if that is positive, then you admit the patient if needed. Then start IV antibiotics if the child is vomiting. But if the child is well, you can start them on oral antibiotics.
Oral antibiotics, yes.
Now, urine culture, when do you consider that as a significant bacteriuria or significant culture?
Sir, depending upon how you take the sample, sir.
So how are the methods of sample collection? One is
adhesive urine bag, sir.
Okay.
One more is periurethral catheterization. Another one is suprapubic aspiration under ultrasound guidance.
Then there is one more common method which you have left out.
Adhesive bag, sir. Adhesive urine bag.
No, that is okay. But is that a
midstream urine, sir? That is, if baby is toilet trained, then you can take midstream urine test.
Yeah. So if the baby is toilet trained, you can do a midstream urine.
Yes, sir. In females, it is very difficult. 2-year female.
I agree. So particularly in a boy child, older boy child, you can do that. Okay.
Yes, sir.
Now, how this culture report? How do you differentiate like what is important, what is significant?
Sir, depending upon the sample taken, if it is a midstream urine or adhesive urine bag, single uropathogen and counts greater than 1 lakh, that means 10 power 5, we consider as a significant, sir.
Okay.
And whereas whereas patient is symptomatic and even in midstream also, patient is symptomatic, then you can even consider 50,000 as a significant bacteria. And if it is a periurethral catheterization, normally you'll take 10 power 4 as a significant bacteria. In suprapubic aspiration, some say 10 power 3, or some say even any count positive count is considered as significant bacteria.
So correct. So it all depends on how much. Now let us say that your urine dipstick and bacterial, microscopy are positive, and then you have 50,000 colony count. Is that significant?
Yes, sir, significant, sir.
Yeah. So in the presence of constitutional symptoms or dipstick positive or urine routine positive, a lower count is okay. In the
Yes, sir.
presence of a catheter, it is 10,000, and if it is suprapubic, any count or even 1,000 is significant.
Significant.
All right.
Yes,
So
sir.
you mentioned that this patient probably needs treatment, and then now during the acute phase, are
Yes,
there
sir.
any investigations you want to do?
Acute phase, I will get one ultrasound, sir. First is the ultrasound, basic
So
investigation.
the basic investigation, ultrasound can be done at this stage, and
Yes,
then
sir.
what is that for? Why
Sir?
do you want it?
Sir, I want to know the status of the kidneys. Any hydroerythronephrosis is there? What is the status of the bladder outlet? How is the bladder outlet? I mean, bladder wall thickening, any trabeculations? We have to see the status of the KU.
So all that you will know when you are doing this. So that is how this is helping. Okay. So
Yes, sir.
that is fine. Now, what about this further evaluation?
Sir, as per Indian Academy of Pediatrics, age between 1 to 5 years of age, we normally consider ultrasound initially. If ultrasound is abnormal, we will proceed to VCUG and DMSA and VCUG. If it is normal, then you can do a DMSA scan, sir, as a first investigation. If DMSA scan is abnormal, then you plan for VCUG.
So what is that approach called?
Sir, top-down approach, sir.
Why is it being followed? Reasoning?
Sir, because in top-down approach, because MCU is an invasive technique, and DMSA scan will helps in preventing unnecessary MCUs in at least 40 to 50% of cases. That doesn't need any treatment or follow-up also.
Okay. So basically, according to the Indian Academy, if your child is 1 to 5 year old, you do the DMSA first. What about the
Yes.
child who is if the child is less than 1 year old?
Then MCU is the first, sir. You do bottom-up approach, sir.
Okay. So you prefer to do MCU. The reasoning?
Sir,
What is the reasoning?
sir, in less than 1 year of age, grading of reflex is important, sir, to know the resolution status.
Okay. Now, one of the reasoning is the scarring is very high during infancy,
First
and the
year.
chance of reflux is also very high during infancy in a child with a UTI. So
Yes, sir.
your pickup rate of your VCUG is much higher.
Higher. Okay, sir.
So you might as well do that. Okay. And
Okay,
in
sir.
a child older than 5 years, what is the plan? What do you do?
Sir, more than 5 years, only ultrasound they indicated, sir. There is no need for no indication for DMSA or MCU.
So as you have said, this is the kind of top down and bottom up approach where less than 1 year you go for VCG first, and then 1 to 5 more than you go to a DMSA, and then in more than 5 years, if the ultrasound is normal, you probably can wait.
No need.
But can you still have a reflux in the presence of a normal ultrasound?
Sir?
Can you still have?
Yes, sir. Yes, sir. Now, ultrasound can be normal, but reflex may be present. If it is a non-dilated grading, like grade 1 or grade 2, ultrasound may be normal, but still reflex may be present.
That's fine. But usually they suffer low grade, right?
Yes, sir.
In a high grade reflux, there will be some amount of dilatation.
Yes, sir.
Now, in this patient, we have done a DMSA scan, as you have suggested. The first DMSA scan has been done, and
Yes,
you can see the DMSA scan here. Can you see what it shows?
Sir, right kidney is normal, sir. There is no visualized left kidney, sir. Left kidney is not
Are there any
visualized.
scarring there? Can you see any scars?
Actually, it's well demarcated and well outlined. There is no
So
specific
this
scarring.
is in a DMSA scan, this is what you look at. So if the outline is whether the contour is in the normal renal shape, whether there is any photopenic areas,
Yeah, it's
and whether
present.
it is a uniform uptake is there. So here it is no scars. Okay,
Yes, sir.
on the right side. What about the
Right.
left side?
Left side, there is no visualization, sir. Kidney is
Oh,
not
sorry.
visualized.
So is that something which bothers you, or?
Sir, it may be non-functioning kidney related MCDK, multicystic dysplastic kidney on right left side.
Now, among the congenital anomalies of various urinary tract, what are the conditions where a reflux is commonly associated?
Sir, reflex is commonly associated. If it is a MCDK on one side, ipsilateral side, reflex is present on contralateral side, sir.
Okay, then
One unilateral, one side PUJO, opposite side there may be contralateral VUR, sir.
or the same side also, you can have around
Yes, sir. Same side and also contralateral side. Yes, sir.
Okay, that is fine. But more than that, you have mentioned MCDK like that. There are certain conditions where VUR chances.
Horseshoe shaped kidney, pelvic kidneys are also associated.
Pelvic kidneys can have. Then what else? Cross fused ectopia.
Cross fused ectopia, sir. Yes, sir.
Then single kidney status, one side absent kidney, they can also have more chance of vesicular reflux.
Reflex. Okay, sir.
And the shrunken kidney, when you see on ultrasound, one side kidney is like 4 centimeter and the other one is like only 1 centimeter. Right?
Yes, sir.
In
yes,
such
sir.
a child, even if you have first UTI, then there is a chance of
reflex.
Reflux. So in this patient, although there is no scar, will you still do an MCU or will you wait?
Sir, there is no need for MCU in this patient, sir.
Well, that is what I have been trying to establish. So
yes,
in a normal patient with both kidneys, if
yes,
you
sir.
have scarring, then you go for an MCU. But
yes,
here,
here it is a single solitary kidney, so maybe one kidney is
can be associated with the VUR. That's what I'm trying to say.
Yes, sir.
Unilateral agenesis or a multicystic kidney or a pelvic kidney, they can have a VUR. So you probably should go for a
MCU.
Now here this is the MCU. So what does it show? And then what do you grade this reflex as?
Sir,
you read the MCU.
Bladder appears to be mildly irregular, but bladder neck and outlet is normal. Bladder neck and urethra is normal. In regarding, there is no reflex into the left kidney. On right side, it looks like grade 3 reflex, but grossly dilated pelvic ulcer system, maybe associated secondary PUJO, maybe, sir.
Okay. So what is the grade of the reflex?
Grade 3 reflex, sir.
Grade 3 or 4. Okay.
Yes, yes, sir.
The spine normal?
Sir?
Is the spine normal or not?
Spine appears to be normal, sir.
I'm not sure about that because L4, L3, L4 is okay, but L5, I mean, L2, L3 are okay. L4 and L5, the spinous process looks like little widened. It is not like a single process. So this may be some amount of spina bifida is there, right? So those are the things which you have to keep in mind, read the entire film, not just your voice is gone.
Yes, sir. Yes, sir.
Okay.
Yes, sir.
So, you have to keep that. Now, in this patient, what is your management? Hello? I think I'll wait for Harish to join back. Can you join? Okay. I think Harish just got disconnected because there was a loss of power in his place. He'll be joining in a minute.
So I'll try number.
Yeah, no, his power supply has just been restored. It just went and came back, so maybe the internet got disconnected. He's just waiting for it to
disconnected.
reconnect. In between, I couldn't see you also. I thought you had, you were there always, or you were kind of went and came back?
Sir, there is a power. Hello.
Yeah.
Sir, he's in a.
He's coming back.
Yeah, he's coming back.
Sir.
Yeah. So Harish, are you okay? Yeah.
Yes, sir. Yes, sir.
Okay. Now this you are able to see the images. Yeah.
Yes, sir. I am able to see, sir.
So in this patient with this particular finding, and now what are your options in treatment?
Sir, this patient first episode of UTI.
Now where is the reflux? You tell me that.
Sir, I can't understand, sir.
No, which side is the reflux?
Reflux is on right side, sir.
And which is the functioning kidney?
Only functioning kidney is on right side. So this patient need antibiotic prophylaxis initially. If there is any breakthrough UTI, then we can plan for definitive procedure like surgery, sir.
Okay. So now in this patient, if do you have a low threshold to wait, or you will keep?
Sir, low threshold to wait, sir, because single surviving kidney. So we have to protect the kidney at any cost. So
okay. What are the options you have in intervention?
Sir, it's about 2 years old female, so you can go for definitive procedure for reflex.
Like what?
Sir, there are different types. Sir, it is divided into different type of surgeries.
No. You don't go there right away. What are the? Can you do anything else before going to surgery? Are there any other intervention available?
Sir, endoscopic injections, sir. Sting is available.
So you think it will work in this patient or what?
Yes, sir. Grade 3, it has very good chance, sir. Up to grade 3, it is around 70 to 80%. It's very good.
Can you try that in this patient?
Yes, sir.
Being a single kidney, you may be worried about reimplantation.
Sir, even after endoscopic injection, we can plan for reimplantation as a secondary procedure, sir. If there is still persistent, we can give one attempt of endoscopic injection.
Okay. What endoscopic agents materials are used for sting procedure? Sting procedure is usually short notes for you. So what are the different agents used for sting procedure?
Sir, one is coapatite, it is called calcium hydroxyapatite. Another one is macroplastic, which consists of polydimethyl siloxane. And another one is PTFE, sir. PTFE in glycerin solution. And another one is a dextronomer, sir. Deflux. Dextronomer.
So what is dextronomer?
It is called deflux. It is a dextronomer in hyaluronic acid, sir.
Okay. Is there any other reagent which is also being used nowadays instead of dextronomer? This deflux. There is one more agent which is being used for commonly abroad.
G-plus, sir?
No. So for vesicouretic reflux, sting procedure, in addition to this deflux, of course, deflux doesn't come these days. There is a different material called Dexel is being used these days.
Yes, sir. Along with silicon, they are using, sir.
No, not silicon. Silicon is an old material. So silicon, Teflon, macroplastic, autologous chondrocytes, all have been used in the past. Okay.
Yes.
In the current practice, we are using more of this dextronomer hyaluronic acid, which is either available in the name of a deflux or Dexel. Yes. Now, one more agent is come up, which is now all being used abroad. Now, I don't know whether it is available in India. We have not used it. What is it called?
I don't know, sir.
The trade name is Vantrace. What is Vantrace? What is the chemical in Vantrace?
I have to check, sir.
So polyacrylate polyalcohol. So that is another material where a lot of research papers have come. It is equally efficient and it is being used. Okay.
Yes, sir.
So that is another agent which is used exactly like your sting procedure. Now, as I said, sting procedure is a short note. So how do you do sting procedure?
Sir, it is first proposed, the technique is proposed by Puri and O'Donnell, sir. They said it is a subtrigonal technique. That means 2 to 3 mm distal to the ureteric orifice. You insert the needle with bevel up. I mean 2 to 3 mm distal to the ureteric orifice. Then you have to submucosally you have to insert the needle for 4 to 5 mm. Then inflate, sir. Then you have to inject 0.1 to 0.2 ml of this.
0.2 ml is nothing. So the total quantity available there is around 1 ml.
No, sir. 0.1 to 0.2 you have to first give. Then you have to see whether it is causing volcanic effect on the ureteric orifice. Then if it is the normal position, you can give the normal, or you can adjust the needle by slight, and you can give the remaining injections.
So how much is usually used?
Normally 1 cc, sir.
Okay, so you probably need around some 0.8 to 1 ml,
Yes, sir.
1
0.8
ml
to
on
1
one
cc.
side. Now, what are the other methods? Is there any other method apart from sting procedure?
Hydro heat and double take heat technique is
What is
they're
that?
using.
What is
Hydro distension intraluminal techniques. Sir.
Hydro distension implantation.
Yes,
Okay.
sir.
So, what are the advantages and disadvantages of a sting procedure?
Sir, advantages, it is a office procedure, sir. We can discharge the patient on same day. No need for catheterization. No need for general anesthesia.
Okay.
Whereas the disadvantages of sting procedures are they have a chance of, if it is the particle size is more, there is chance of carcinogenesis on long term. There is a chance of particle migration, particularly towards the bladder neck. The efficacy will be lost. There may be loss of tissues. That means some, like dextromer, it is a chance of absorption into the tissues. So the quantity will be get less at the same time.
Loss of volume, not
loss
loss
of volume.
tissue.
Yes, sir.
Okay.
Yes,
so what happens when you when that happens?
Reflex again ensues, sir. I mean, the efficacy
So
will
it's called recurrent VUR.
recurrent VUR. Yes.
So recurrence can happen. Then what is one major drawback in Indian setting where we don't have insurance?
Yes. Okay.
What is it? What is the disadvantage of this material?
No insurance, sir.
No, in India we don't have, all of them don't have insurance, right?
Yes, sir.
So
Costly,
what is
sir.
costly? It's very expensive. The material is very expensive.
Expensive.
So
Yes.
when you are doing 2 ml of this material, probably the cost will be exceed already the cost of open surgery.
Yes.
Right?
Yes,
Okay.
sir. Yes.
So now we will go to the next one. This is a 6-month-old boy. Okay.
Okay, sir. Okay, sir.
He had 3 episodes of febrile urinary tract infection.
Okay, sir.
He's already on antibiotic prophylaxis and he has
Still
had a
breakthrough.
breakthrough infection. So how do you grade VUR?
Sir, it is bladder is appears to be well distended, smooth walled, and there is bladder neck appears to be normal. There is no difference in caliber between posterior and anterior urethra. And on left side, it is a grade 3 VUR, and on right side, it is a grade 5 VUR, sir.
So now in this patient, what is the interventions you can plan?
Sir, this patient, even on antibiotic prophylaxis, there is a multiple episodes of febrile UTI. So I want to proceed with temporary diversion technique, sir. Because he is 6 months, I cannot proceed with definitive management. So temporary diversion techniques, you can go for a Blacksum vesicostomy or maybe cutaneous ureterostomy, sir. On right side, particularly.
So you can do that. Now the parents don't want any temporary procedures. They want they don't want a stoma. Anything else you can do? For example,
Circumcision, sir. Circumcision
procedure will work in this patient or not?
Sir, sting grade 5, the chance of it is a I mean, ureteric orifice may be very large, and even
Right.
1 cc you cannot give.
On the left side it might work, on the right side it may not work.
Difficult, sir. Coaptation won't come.
Which is correct. Now, you said that in 6-month-old that reimplantation can be difficult. Why did you say that?
Sir, because trigone is not well developed. Normally, we do infratrigonal Cohen's technique. For that, trigone should be somewhat well developed, sir, for do the technique.
Okay. And in the earlier case, you said that you can do something else and then see whether that works. So, being a boy child, you can also try a
Circumcision, sir.
Circumcision, buy some time, and then maybe when he reaches 9-month-old, you can plan an intervention. right?
Yes, sir. Yes, sir.
That is also possible. I mean, basically, you want a bigger sized bladder with a
Yes,
good
sir.
amount of trigone, then only
Trigone.
your reimplantation can succeed.
Yes, sir.
So here is a case where probably a reimplantation is better than a sting procedure.
Yes, sir.
So what are the approaches possible for reimplantation? First, tell me the approaches, and then we'll go to the operations.
Sir, it may be suprahiatal or infrahiatal technique.
No, that is the options, the different techniques.
Okay,
What
sir.
are the
Approaches? It may be open, laparoscopic, or robotic, sir.
So you can do open, you can do laparoscopic, you can do the vesicoscopic. Vesicoscopic means you put the camera directly into the bladder,
Yes,
or
sir.
you can do robotic.
Robotic.
Now coming to the different techniques, what are the different techniques of reimplantation you call? Ureteric reimplantation can be, management of vesicular reflux can be a long question. So
Yes,
you
sir.
may have to discuss about the different types of ureteric reimplantation. How do you classivate? And
One is
pros and-
suprahiatal, another one is infrahiatal. One type of approach. Another we can also differentiate as a intravesical approach, intravesical approaches or extravesical approach.
So can you give me some examples?
Sir, intravesical approach. It was first technique was described by Palatino Ledbetter, and another commonly used are Cohen's transragonal in
So
case
what
of
is
bilateral.
Palatino Ledbetter? Is it a supratrigonal or infratrigonal?
Palatino Ledbetter is a supratrigonal, sir.
So what do you mean by that? What do you mean by that term?
Sir, that means the ureteric orifice, I mean, on final position of the ureteric orifice, it is not within the near the bladder neck, sir. It is at the normal position where it is previous. It is there. Then
Okay.
tunneling is done superior over the normal orifice, sir.
Good. So what are the types of infratrigonal reimplantations?
Infratrigonal, one is Cohen's transragonal in case of bilateral ureteric reflex. Another one is Gil-Vernet, and another one is Glenn Anderson, sir.
Okay. And whatever, give me an example of an extravesical reimplantation.
Extravesical Lichtenegger, sir.
Lichtenegger. Okay. Now, how do you perform a Cohen's reimplantation?
Sir, Cohen's to be done, normally it is useful when the ureteric orifice is laterally oriented bilaterally with bilateral reflex. In that cases, normally we propose.
You just tell me the simply one or two steps, important steps, like how you approach, how you proceed, like 2 or 3 steps.
Cohen's
What
first
incision?
step incision is financial incision, sir.
Okay. Then
And
what
then
do
you
you
have
do?
to separate the rectus in the midline, then open
That's
the
okay.
bladder.
Okay. How do
then
you
we
open
can-
the bladder?
Sir,
How do you open the bladder?
we have to give in a horizontal incision, sir.
It's usually vertical incision.
Okay, sorry. Okay, sir. Vertical
Okay.
incision.
Then
Okay,
what
sir.
do you do?
Then normally you keep a mop within the fundus.
Yeah. So that is the idea is to retract the
Retract the
bladder
bladder.
and then expose the trigone.
Trigone, yes, sir.
Then what do you do?
Then you have to mobilize the ureter all around
And then
without injuring to the vas deferens and blood vessels.
okay.
Then after adequate mobilization on both sides, then you have to create a submucosal tunnel, sir. I mean, mucosa can be lifted up from the detrusor
Okay.
in the tissue between the two ureters. Then you have to cross the ureters, and then you have to ligate. Then you have to suture the ureters at the lowest position. I mean, infratrigonal close to the bladder neck, and detrusor raphe it should be done on superior position, sir.
No ligate. You just have to fix it across and then put it in a crossed position.
Crossed position.
The
Yes, sir.
opposite side. Now, what are the disadvantages of Cohen's reimplantation?
Sir, future endoscopy is very difficult, sir, because the natural orifice position is lost.
So that is one disadvantage of this particular reimplantation, although it is very commonly done
Yes, sir.
procedure, right? So that is about Cohen's reimplantation. And I won't go into the detail. Can you do the Cohen's reimplantation through endoscopic method?
Yes, sir.
Minimally invasive?
Yes, sir. Through vesicoscopy you can
Through
do, sir.
vesicoscopy. So you can do through vesicoscopy. So that is also possible. Okay.
Yes, sir.
So now we will leave that and then go to the next one. Now this is a 6-year-old girl with a recurrent urinary tract infection. Okay.
Yes, sir. Yes, sir.
Now here is the MCU in this patient.
Yes, sir. It is bladder appears to be normal and urethra bladder neck is normal, sir. It is a grade 2 reflex on right side, and it is a grade 4 reflex on left side, sir. Grade 4 or grade 5.
Okay, and what do you comment on the lower end of the ureter?
Sir, lower end of the ureter is very much dilated. It may be associated para-urethral diverticula or maybe ureterosis.
Okay, and what is the diameter of the ureter? Is it normal or very quite dilated?
Very much dilated, sir. Normally,
What do you
mega
call
ureter,
that?
it is considered greater than 8 to 1 centimeter, 8
So
mm to 1
what do you
centimeter.
call that?
Sir,
When
mega
we
ureter.
say mega ureter. So what are the types of mega ureter?
Sir, mega ureter is differentiated into 4 types, sir. One is obstructing, second one reflexing, third one obstructing, reflexing, and fourth one is non-obstructing, non-reflexing.
During reimplantation in this particular patient, what else you may have to do for the ureter?
Sir, if it is associated with para-urethral diverticula, you have to do diverticulectomy followed by reimplant.
Okay. Yeah, and what about the ureter? Can you just reimplant it or?
Sir, you have to do excisional, I mean, not excisional, tapering you have to be done, sir. Whether
Why
it is
do you do the
excisional or
tapering?
non-excisional.
So why
Sir?
do you do the tapering?
Sir, because you have to maintain the Peak-Win ratio, which is 5:1 ratio. That means diameter is to intravesical length of the ureter. That means tunneled ureter, it should be 5:1, sir.
So Peak-Win ratio is what you want to maintain. Now, what
Yes,
is the role of urodynamics in this patient? Would you have done a urodynamics in this patient?
not done, but this patient urodynamics will be little difficult because reflex is there. Chance of getting accurate results is very difficult, sir.
That's right. So when do you plan a urodynamic in a patient with vesicular urethritis? What are the indications? Do you do always in older girls or some children you do it?
No, sir. Patients particularly with dysfunctional voiding or bowel bladder dysfunction, or
Okay.
even at 60 years of age, there is no proper toilet training, then we can go for
Okay.
UDS.
So if there is any history suggestive of dysfunctional bladder,
Yes, sir.
dysfunctional voiding or bowel bladder dysfunction, or on the MCU the bladder contour looks abnormal, irregular,
Abnormal.
complicated,
Yes,
then you may have to do an MCU. Okay.
yes.
Now this patient has got a 4-year-old brother.
Okay, sir.
What is the chance of a familial reflux in a sibling?
Sir, if it is identical twins, it's normally around 80 to 100%. If it is a
This is
non-identical
not a
twins,
twin, this is a sibling.
okay, then it is 40 to 50%, sir.
It's roughly around 30-40%. Okay.
Yes, sir.
Now how do we screen them?
Sir, radionuclide cystogram, sir. Ultrasound followed by radionuclide cystogram.
You can do ultrasound and radionuclide. So what are the types of radionuclide cystogram?
So there are 2 types, sir. One is direct and another one is indirect radionucleotide cystogram, sir.
Okay.
Indirect radionucleotide cystogram, we give the radionucleotide through the IV route, sir. Then followed by, then after drainage through the kidney, then into the bladder, then ask the patient to void. If then there is a reflex in voiding, then we see for reflex. That is indirect
good
method.
procedure or is it a disadvantageous procedure? Some disadvantages.
It is a disadvantage, sir. So it is a very long technique, which I mean.
Not only that, what is the main disadvantage? The
Sir,
upper tract already has got some traces.
Already got some new radionuclide within the kidney, so cannot say the reflex. I mean, you cannot grade it properly.
That is the problem. Now,
Yes,
what about the direct? What are the methods of direct radionuclide cystogram?
Sir, it is divided 2 methods we can do, sir. One is through percutaneous route, another one is suprapubic route, sir.
Okay, which is better?
Suprapubic is better, sir.
Okay, why?
Less chance of trauma, less inconvenience to the patient.
What about less catheterization related risks? Okay.
Risk, yes, sir.
What is the
Chance of
advantage
infection.
of and disadvantage of radionuclide cystogram compared to a conventional MCU?
Sir, radionuclide cystogram has very low radiation, sir. I mean, it is it is 100 times less than MCU, single MCU.
What is the disadvantage?
Disadvantage, it cannot grade reflex into 5 grades properly, and grade 1 you cannot identify in MCU itself. I mean, radionuclide cystogram, you cannot identify grade 1 reflex.
So this is a radionuclide cystogram of her brother.
Yes,
okay.
sir.
So
Yes,
what do
sir.
you think is there?
He has grade around grade 2 or grade 3 reflex on right side, sir.
How many grades are there in radionuclide cystogram?
Normally we divide into 3 grades. It's look like grade
so 3 corresponds to grade 4 and 5.
Yes, sir.
All right.
Yes, sir.
So that is how it is divided. So, but it's very difficult to grade. And then what is the other disadvantage here?
Sir,
One is you cannot grade like 1 to 5.
yes,
What
sir.
is the
One, you cannot identify the any bladder pathology or outlet.
You
outlet
cannot
pathology
identify
of
the
bladder.
bladder pathology, counter, or urethral pathology. So that is one of the disadvantages. So nuclear radionuclide cystogram can be a short notes. So even in can be asked in Viva. So you have to discuss all the advantages and disadvantages. Okay. Now this is a 3.5-year-old child with recurrent UTI. Now what do you comment on the DMSA scan?
He has photopenic areas on both upper pole and lower pole on both sides. Sir.
So there is scarring on both poles. Why is it more common in the both poles?
Because of compound papillae leads to intrarenal reflex.
Okay, so that is the reason why it happens more on the poles. Now,
Poles.
can you read the MCU in this patient?
Sir, bladder is smooth walled, good capacity, and urethra appears to be normal. Bladder neck is normal. And in related to reflex, it is a grade 3 or 4 reflex on right side and grade 2 reflex on left side. Sir.
So here, what intervention is possible?
Sir, 3.5 years recurrent UTI. So this patient can be managed with endoscopic.
Correct. So
sting
here
procedure,
it's a
sir.
low-grade reflux. You can proceed. You can even try a sting procedure.
Sting procedure.
Right? Okay.
Yes, sir.
Now this is an 8-year-old child with a urinary tract infection. What is the particular finding you see here?
Sir, diverticular, sir.
There's a large paraurethric diverticulum.
Paraurethral diverticular.
What is the chance of spontaneous resolution in this patient?
Spontaneous resolution is very low, sir. I mean, as compared to it's look like a grade 2 reflex, but as compared to normal patients without any paraurethral diverticular, spontaneous resolution is very low, sir. It's around 20
During
10 to 20%.
during surgery, what important precautions you have to do in this patient? I mean, what is the difference between normal reimplantation and reimplantation in this patient?
In this reimplantation, we have to remove the entire diverticula, then do detrosography and infratrigonal reimplantation of the ureter.
So often there is a defect in the detrusor, which
Yes,
you
sir.
may have to repair.
Detrosography.
3-year-old girl with a urinary tract infection. So what do you see in this patient?
Sir, on DMSA, it looks like parenchyma uptake is normal on both sides, sir. On DMSA, there is a no photopenic areas.
But the right kidney looks normal or does it look double?
Yes, sir. No photopenic areas, and it is a right kidney duplex, complete duplex ureter is there, sir.
Okay. And the MCU?
MCU bilateral reflex is there, sir. I mean, both
No.
the duplex mites have a reflex.
On the left kidney is there a reflex?
No, I mean both duplex ureters have reflex, sir, on right side.
Left kidney is not reflexing.
Yes, sir.
Right kidney, there is a reflux into upper moiety and the lower moiety.
And also lower moiety.
So use proper terminologies.
Yes, sir. Yes, sir.
Okay. And
Yes,
the duplication appears to be complete.
Complete.
Or whatever. And when you see, I don't know whether it is complete, because in a complete duplication, do you expect reflux on both moieties?
Normally, it is reflex is normally seen in lower moiety, sir, because it is laterally and cephaloid position.
Why?
Because of lateral position, submucosal tunneling and short VUJ is present, sir, in case of lower moiety.
Okay, so usually it affects
primary
the lower moiety because of that Weigert-Mayer rule, where that the development is like that. The lower moiety is the one which is inserting more.
Cephaloid and laterally positioned, sir.
So there is a lesser tunnel there.
Yes.
Now in this patient, what is the management? What is the chance of spontaneous resolution in this case?
Sir, reflex with associated abnormalities, chance of spontaneous resolution is low. That to 3 years old child with recurrent UTI. I want to proceed with definitive management with common sheath ureteric reimplantation, sir.
So you probably need something called a common sheath reimplantation. All right.
Yes, sir.
So that is the difference. And what about the sting procedure? Has it been tried and then has it worked in this patient?
Sir, sting procedure in other patients like neuropathic bladders or diverticulars or in duplex moieties, chance of success is very low, sir. Most of the studies shows the chance of
So a common sheath reimplantation is a better option.
better option.
Now,
Yes,
if
sir.
the lower moiety is not functioning
Okay,
and
sir.
it is refluxing, what will you do?
Then you go for heminephrectomy, sir. Nephrectomy along with ureterectomy.
Via?
Sir, via abdominal approach, sir.
You mean make one incision in the loin and then one in the suprapubic region, or
One in the line, one in the suprapubic region, sir.
is there a
Two.
better way to do that?
Mm,
What approach can you do?
don't know.
When you do heminephrectomy these days, we are doing it via open or minimally invasive?
Laparoscopic approach, sir. Laparoscopic, you can mobilize the kidney laparoscopically, then make another incision or incision near the bladder, remove the entire
So
kidney
you
and
can do
ureter.
laparoscopic heminephrouretrectomy. Okay.
Yes, sir.
So that's what I will want to say. So with that, we will come to the end of this discussion. So I will stop here, and if there are any particular questions or doubts, I'll answer. Otherwise, we will end this session. Dr. Nitish, is that okay? Are there any particular questions I need to answer from the audience, or we'll answer it later? So if there are no questions, so you have any doubts, Harish?
No, sir.
Okay, so we'll stop it here. Thank you for joining. And then, if there are any questions, I will answer in the chat box later.
Thank you, sir.
Thank you.
Thanks.
Thank you, sir. Thanks a lot, Harish.